Hello, you are most welcome, ladies and gentlemen, to Tuesday Night Anatomy with Daniel Okwan. Of course, today's meeting also marks one of the power behind the voice sections. My friends, today I continue with the histological identification of organs. Okay, so it means that there's a second part of that video series. My friends, today's meeting, I quickly take you through some few slides. Okay, try to orient you the way you are supposed to answer some questions. For instance, if you see it in any exam, okay, that you, of course, encounter. So my friends, without wasting my time, let's set the ball rolling. Looking at what I have for you today. My friends, that's the first guy. Okay, so sometimes a histological section, okay, like this, micrograph of a section like this could be given to you for you to identify. My friends, as I've indicated, this is the section of the skeletal muscle tissue. Now, why is it so? Because, my friends, for us to say that we are looking at as a tissue, then it means that it will be made up of course, similar cells. And my friends, what sort of cells are we talking about here? My friends, we are talking about myocytes or the muscle cell. Now, don't forget that whenever I talk about the muscle cell, it's the same as the muscle fiber. Together form what we call this muscle tissue. But precisely, we are talking about skeletal muscle tissue. Now, why? Because this is a cell, okay? This whole thing, cylindrical shaped guys that you find over here, these are what we call the myocytes of the skeletal muscle tissue. Okay, so they are cylindrical shape. Now we don't see the ends. Now normally the ends will be rounded. That's another thing. And one important thing that we find with these things is that importantly, they will show this kind of things we call cross striations. Now don't forget that this is a longitudinal section. Now if it had been a transverse section, then obviously we won't be able to clearly, although maybe seeing certain things, but may not be depict that kind of cross striations. So clearly, because there's a longitudinal section, we can appreciate that. And also, importantly, we can also appreciate that if you take just one muscle cell, it will be endowed with several nuclei, which are flattened, okay, and they are displaced towards the periphery of the muscle fiber. Okay, so these are the useful things which suggest to you that this is a skeletal muscle, tissue. Now, because we have three kinds of muscle tissues histologically, then you may want to give other negative diagnostic, features, saying that we don't see certain things over here, which tells us that confidently this is actually a skeletal muscle tissue. Now, one thing, we don't see branching, because we see branching occurring evidently in something we call cardiac muscles. We don't see branching, so we can indicate that no branching is occurring over here. But my friends, the point is that yes, it's not always, but we may see some branching, okay, occurring in skeletal muscle fibers. But classically, okay, strictly speaking, skeletal muscle fibers do not show branching. Of course, because there's a muscle fiber, okay, a muscle cell, then in between adjacent muscle fibers, okay, this area is actually connective tissue in between them, and that is something you call endomysium. Of course, together, this whole thing, okay, if you have several units of these, muscle fibers, okay, they will form this kind of fascicle, which will be covered by what we call the perimysium. And of course, eventually, several of these fascicles, okay, together will be covered by another connective sheath, something we call the epimysium. Join them, okay, getting to the point which will be, of course, attaching to, of course, for instance, the bone, and in such a case, we'll be calling it the tendon. Okay, so these are some of the, variations. Now remember, there's a rapid section. Already, I've done videos on these ones, okay? So that's what we are going to go through. Now, please don't forget that you may be required to tell us areas in the human body where these ones, okay, will be located, for instance. Okay, for instance, around the eyeball, okay, you may have some of these muscles, we call them, the extraocular muscles. They will be there. Okay, so you should be able to tell some of these things in the oral cavity, okay, on the tongue, okay. If you look at it, for instance, the palate, okay, all these areas, you'll be having all these skeletal muscle fibers. Okay, not only that, even if we look at some portion of the esophagus, last week we discussed some of these things, okay, upper 1/3 portion together with some portion of the middle 1/3 portion of the esophagus. Of course, some portion of the anal canal. Yes, we'll be having these skeletal muscle fibers. So my friends, importantly, you should be able to tell these areas that we can have some of these, muscle fibers. You need to understand some of these. For instance, if I look at my cheek, okay, if I look at my lip, all these things are potential areas that you will be having these skeletal muscle fibers. Okay, so that is a useful thing I want you to know. Now, the other thing is that the point is that you saw that there were cross striations, okay, in that longitudinal section of the skeletal muscle tissue. This time around, what we are seeing over here is the cardiac muscle tissue. Yes, cardiac muscle. Okay, and so for us to appreciate that that's the cardiac muscle tissue, then we should be seeing the fibers, we should be seeing the cells. Now, how will the cells, okay, be different? The point is that in the case of what you call the skeletal muscle fibers, we said we saw the cross striations. Yes, similar thing also occurs in the case of the cardiac muscle tissue, because the fibers over there will show that kind of cross striations. But my friends, the point is that if you are comparing these two guys under light microscopy, then you want to see that there will be more prominence, okay, as far as what we call the cross striations are concerned in the case of the skeletal muscle fibers compared to that of the cardiac muscle fibers. That's the first thing. But by and large, what we say is that both of them show cross striations, and that is why whenever you talk about striated muscles, then you have to include both skeletal muscle fibers and of course the cardiac muscle fibers. Okay, that is one thing. Now, what is the other thing? Now, the other thing is that I told you that in the case of the cardiac skeletal muscle fibers, we said that they were cylindrical in shape. They didn't show that kind of branching. Okay, evidently they were not present. But my friends, importantly, in the case of these cardiac muscle fibers, yes, they show extensive branching of the fibers. They show extensive branching of the fibers. I'll come to that one. But the next thing I want you to know is that we said that in the case of what we call the skeletal muscle fibers, we saw these peripheral shape look like, okay, which were multinucleated, a lot of them show multinucleation, and then of course, and that is why we say that skeletal muscle fiber, they form structural syncytium. In the case of cardiac muscle fibers, as we find over here, my friends, usually you may be seeing per fiber just one nucleus, or it may be just binucleate, okay, two nuclei, okay, per fiber. The point is that they show this kind of branching. Now, what else? The point again I want to show over here is that, okay, connecting adjacent cardiac muscle fibers or muscle cells, okay, through this kind of branching that they are showing is something that we call intercalated disc. So you see these kind of dark areas over here, even at light microscope, you can appreciate them. These are what we call the intercalated disc. But my friends, another thing that you appreciate over here is that the nuclei over here, they are oval in shape. That may not be very useful, okay, if you are comparing it with, skeletal muscle fibers. But of course, we can appreciate that they are oval over here. Okay, so we find intercalated disc. Now, the presence of intercalated disc that we find in the case of the cardiac muscle fibers is the one which ensures that the ions, okay, can move rapidly from, of course, if one cardiomyocyte gets depolarized, it can quickly, affect the other, okay, for ensuring that there's that kind of unison as far as contraction of the cardiomyocytes, okay, are concerned. Okay, and that is why I want you to know that because of these, intercalated disc, the cardiomyocytes, okay, they exhibit something we describe as being functional syncytium. Functional syncytium. Now, although we have, of course, other things, okay, but the most important thing I want you to know as far as the junctions, okay, are concerned over here is for you to appreciate that you have desmosomes. Okay, you have desmosomes, okay, and then the other important guy, which is ensuring that the ions rapidly move, okay, to adjacent cardiomyocyte through that branching, is something that we call gap junctions. And of course, I've explained it to you that gap junctions are communication junctions, and that is why the ions can quickly move, okay, and spread, okay, that kind of polarization to neighboring cardiomyocytes. Okay, that's a useful thing. Now, you may be required to, tell us some of these areas in the human body that you may be finding, of course, all these, cardiomyocytes we are talking about. Of course, no doubt about it, whenever we talk about cardio, we are talking about, that of the heart. And so we look at the musculature of the heart. Okay, that's in the tunica media. Okay, that portion of the heart. What are we talking about? We are talking about, the myocardium. In the myocardium, you'll be finding, of course, these cardiac muscles over there. Now, is that the only place? No. Now, even the great vessels, which either drain into, of course, the heart, or they empty, okay, from the heart, or they take that blood away from the heart. These great vessels, their proximal or distalmost portions may present them with some of these, cardiomyocytes. Yes, importantly, we can talk about the, initial portion of course, the ascending aorta. Okay, we can talk about the initial portion of course, the pulmonary trunk. Okay, the most proximal portions of these guys. Okay, I can also talk about the distalmost portions of course, the superior vena cava, and of course, the inferior vena cava as they empty into the right atrium of the heart. So you should be able to tell, quickly tell us some of these things, which of course we can appreciate over here. Now, the next guy that we appreciate over here, yes, this time around, it doesn't show striations, and that's why we say it is an unstriated, muscle, or it will contain, unstriated muscle fibers. Okay, and this time around we find it associated with viscera. Okay, when we talk about viscera, we are talking about these internal organs largely derived from, of course, endoderm. Okay, so we'll be finding that muscle in there, and that is why this muscle, although we simply call it smooth muscle, can also be called visceral muscle. And so what is the distinction? It will lack cross striations, even in longitudinal section. Okay, it will lack cross striation. Okay, that's the first thing. But the point is that this time around, the shape becomes spindle shape. They are spindle shape, and the nuclei, you can see, this kind of flattened nuclei, which will be centrally placed, just like what we find in the cardiomyocyte. They will be centrally placed. Opposite to that, we find for the for the skeletal muscle fibers, which will be peripherally, placed. This time they will be centrally placed. Okay, they will have this kind of tapering ends, and that is why we describe these cells as being either you say fusiform, or we say, they are, you can see they are slender-like, okay, so to speak. And so I want you to appreciate that one. Okay, so these are the cells we are talking about. These are the smooth muscle cells. Okay, so we find these things. Of course, they won't be cylindrical. They will lack cross striation. You have to indicate that. You have to indicate also that they don't show branching. You have to also indicate that they will lack these kind of areas that we talk about in the case of the cardiomyocyte by way of the intercalated disc. They will lack it. Okay, so these are useful whenever you are commenting. Okay, you should be able to tell us as many important things as possible. Now, I am very much interested in this guy for the reason that most of the things that we're talking about, okay, as far as we move on with these slides to be concerned, we're talking about mainly smooth muscle things. Okay, so you should appreciate this one. Of course, you should be able to tell, as I said, is viscera, so areas in the body that we're going to find them. Okay, so for instance, the lower portion of the esophagus, lower and third portion. Okay, stomach, the intestine, everywhere over there. Okay, talking about, of course, talking about the female, talking about the talking about the fallopian tube, talking about the uterus, okay, talk about the smooth muscles, which we find in the breast and all that. And whenever we talk about secretory acini, secretory acini, okay, for instance, if you look at the parotid gland, if you look at that of the submandible, whatever, they are secretory acini. Usually, they will be surrounded, yes, by some kind of smooth muscles. Okay, some cells which have, this kind of actin in there by way of the myoepithelial cells. Yeah, that one is actually epithelial in origin. But what I'm trying to say is that, we are going to get some areas in the human body which will be finding. Okay, if you look at the ureter, the urinary bladder, okay, like the detrusor muscle, all these ones. Okay, if you look at the blood vessels, okay, by way of most of these blood vessels which are distant, okay, from the heart. And of course, the tunica media will be having all these, smooth muscles over there. So you should be able to quickly, come out with some of these things. Yeah, you shouldn't even forget about the skin, the erector pili muscle, okay, the one I talked about last week, okay, will be smooth muscle fibers. Okay, so you should be able to appreciate it. And remember that just like the cardiac muscles, okay, and of course the smooth muscles, they will be what? Involuntary. You don't really have control over them. In the case of the skeletal muscle fibers, of course, they will, of course, be, voluntary in nature. Now, having looked at this, there's one more basic thing I have to talk about, and that one could also be given to you, the slide of the fibrocartilage. The slide of the fibrocartilage. And then how do you know about this guy? Okay, we know we have three kinds of cartilages, and I begin with the fibrocartilage. The fibrocartilage, yes, the idea is that it has a lot of fibers, and mainly I talk about the collagen type 1, fiber. Okay, normally I talk about collagen type 2, but this time it will be well endowed with collagen type 1. Yes, of course, it may also have some bit of collagen type 2, but importantly, the predominant one will be collagen type 1. So we say it is highly, fibrous, just like what we find in the bone, and that's why we call it fibrocartilage. So it means that, importantly, it may be having features which resemble that of a special dense irregular connective tissue. But my friends, the good news is that you will see that it will be having all these guys, okay, arranging themselves in a row or linearly arranged, these guys, okay, or seeing their dark nuclei, sitting in lacunae. These are chondrocytes of the fibrocartilage. Okay, so I want you to appreciate this one. And my friends, the question is, why do they arrange themselves linearly in this manner? The reason is that because they are well endowed with a lot of collagen, type 1. And the tensile strength, okay, we get it from collagen. And so we are able to squeeze in between. So in between adjacent roots, we have these, a lot of bundles of these, collagen type 1, okay, special mainly, so that they can squeeze against these chondrocytes lying in the lacunae, so that they appear to be moving, okay, or lying linearly, or in that kind of rules. Okay, so that is what we'll be seeing. Remember that in the case of fibrocartilage, there will not be any perichondrium. There will not be any perichondrium. Yes, because we have a lot of fibers. Yes, it blends with the neighboring, tissue. Okay, so that is one useful thing I want you to become aware of. They lack isogenous groups also, but rather we see them, okay, the chondrocyte lying in the lacunae and then being linearly arranged, and you can see thick bundles of collagen, especially collagen type 1 fibers, squeezing these ones so that they arrange themselves, linearly, and that they lack perichondrium. Now the question is, you should be able to tell areas in the human body that we find these ones. Remember, I've done these videos, they are there. Okay, there's a rapid section that I want you to appreciate. Yes, whenever you talk about fibrocartilage, then the good news is that just think about you mainly things in the midline of the body. Talk about the annulus fibrosis of the intervertebral disc. Okay, think about that one. Talk about the pubic symphysis. Okay, think about that one. Okay, and then also, my friends, for instance, think about the mandibulosternal joint. Okay, that one over there. Think about that fibrocartilage over there. And then, my friends, don't forget that even the menisci of the knee, okay, these ones will be having all these fibrocartilages. Okay, so I want you to appreciate that these kind of things. For instance, if I look at the articular disc, okay, the one we find it in the temporomandibular joint, yes, it is going to be fibrocartilage in nature. Yes, even think about the TFCC, the triangular fibrocartilaginous complex, okay, something called the articular disc, okay, which ensures that, which is in the wrist area. Okay, I want you to appreciate that one. Okay, so that one too will be having this kind of, fibrocartilage. Now, my friends, the next one I'm talking about, which will be of relevance as far as what we are going to go through is concerned, is the fact that we have what we call hyaline cartilage. This is actually the adult hyaline cartilage. Mainly, yes, it's gradually becoming adult. I will explain. It hasn't fully exhausted its growth by way of the appositional growth, and I will explain that one. So now, the first thing I want you to appreciate is that this time around, we don't see the linear orientation of the chondrocytes lying in lacunae. Yes, they will lie in lacunae, no problem about that one. But the only thing I want you to appreciate is that this time around, you have one lacunae and it may be housing 3, 4, or even 5 chondrocytes. Okay, because of the high interstitial growth taking place, the mitotic activity of the chondrocytes lying in that lacunae. Okay, so that we form something we call cell nests, something we may call isogenous groups. So that one mainly, although we may see some bit of it in the elastic cartilage, whenever you talk about isogenous groups, my friends, think about that of the hyaline cartilage. That's the very useful thing I want you to know. And because we have a lot of, chondrocytes over here lying in the lacunae, that is why the area just around the chondrocyte, okay, will be highly basophilic. And that's why we describe this area to be territorial matrix is present, and then in between them, relatively pale staining areas, which we call it interterritorial matrix. Now, don't forget that whenever you talk about hyaline cartilage, we are saying something that is glassy. Mainly, just like, elastic cartilage, the collagen type which will be well endowed over here, my friends, will be collagen type 2. And my friend, collagen type 2, okay, has, yes, almost the same refractive index, just like, you know, the ground substance, which of course I've explained that mainly we call them aggregates, okay, over there, sulfated proteoglycans. Okay, so for this reason it becomes pale. Okay, I mean, not like pale, it becomes featureless, the ground substance. Okay, over here we don't really see the fibers, unlike in the case of the fibrocartilage, where we saw, you know, abundance of the thick collagenous fibers, mainly the collagen type 1, as I told you. But this time the collagen type 2, we are not able to visibly appreciate them over here under light microscopy, for the reason that it is having the same refractive index as that of the ground substance, the aggregates. So that's useful that you tell us. But my friends, the important thing I want you to know is that this time around, unlike in the case of the fibrocartilage, this guy hyaline cartilage will be well endowed with this area. Okay, I want you to appreciate, because cartilages are avascular. Okay, this guy will be well endowed with something called perichondrum. You know, peri has to do with around. So around this hyaline cartilage, we are going to see this area which we are calling the perichondrum. Now don't forget, as you can see over here, I can see A and B. Okay, now normally that is how we see it. We see the A. That portion is very close to the chondrocytes. Okay, it means the cells. Okay, this becomes of course the inner chondrogenic area, and of course we have the outer fibrous, you know, component, or you can also say inner cellular layer. Okay, so that's one thing I want you to become aware of. Of course, due to something called positional growth, these cells, okay, gradually be converted into these chondrocytes to ensure, okay, the increase in girth of these cartilages. Okay, so I want you to appreciate that one. And so that is why gradually, especially in the adult, what is going to happen is that gradually this whole B area, okay, will eventually become that of the A. Yes, I want you to appreciate that. Okay, so this one will be well endowed with perichondrum. Now, my friends, we know that is the most abundant cartilage that we have in the human body, even the fetus. If we talk about fetal cartilage, okay, fetal skeleton, mainly we are talking about this guy contributing vastly, okay, to it. Okay, now this time around, anything which is related, okay, for instance, special things related to the, nose, nasal septum, most of the cartilages, other cartilage of the nose, okay, most of these things, okay, related to it. Okay, think about, most of the, cartilages of the larynx. Remember that we have 3 paired, 3 unpaired cartilages. Sometimes I say there's a 4th paired cartilage. Okay, so for instance, the areas that we have in the human, if you look at that of the skeleton of the larynx, laryngeal skeleton, okay, if you talk about the thyroid cartilage, okay, the cricoid cartilage, these guys will be hyaline cartilage. Now, if you talk about, now normally some people talk about the arytenoid cartilage being hyaline, but my friends, there's a catch over there, because in the case of the arytenoid cartilage, what we see is that the base will be hard, because sitting on the cricoid cartilage will be hyaline cartilage in nature, but the apices, okay, together with of course the corniculate cartilage and the cuneiform cartilage, which are paired, will be of course elastic in nature. I want you to appreciate some of these things because it could be asked. And my friend, don't forget about the cartilage, okay, where it's also paired. Now normally we expect that it should be hyaline cartilage, but of course from literature we see that it's elastic, and it can even undergo synostosis, becoming bony in the thyroid ligament, lateral thyroid ligament. So I want you to appreciate that one. Okay, please know about these things. Of course, if I talk about the costal cartilages, they are there. Okay, you'll be appreciating all these things, having this kind of these things. Of course, if I talk about the xiphostenar joint, although it's in the midline, it is not going to be fibrocartilage, rather it is going to be hyaline in nature. So now moving away from that, now my friend, this time around, what I want you to know is that under routine hematoxylin and eosin, this cartilage, you won't appreciate it. You won't appreciate the unique features that it has. Yes, so I want you to know that. And so what we have to do is to highlight them using some kind of special stain, like Shikata or stain, like Beowulf's, Van Jessen. Okay, these ones, they could be used, okay, to highlight these structures. Now, this time around, now usually the lacunae, they appear larger, okay, with the cells over there, and you may be seeing, it could be simply placed, one lacuna, one chondrocyte, but sometimes you may have one lacuna and then maybe 2 chondrocytes sitting in there. And that is why I said that, yes, it's due to the interstitial growth, so mitosis will take place, so that one, no problem. But my friends, always try to say that isogenous groups or cell nest, okay, attributed to that of the hyaline cartilage, and leave it in the case of the, elastic cartilage, only that they are larger. As I said, we'll be having collagen type 2. which of course, because it has the same refractivity as the ground substance, we won't see it. But the most predominant fibers that we find is this time around what we call the elastic fibers. Okay, so these elastic fibers, the one we are highlighting using the special stain, for instance, osine, okay, that is what we'll be seeing. Moving all around over here. So importantly is the elastic fibers, so that we know that there's the elastic, cartilage. But don't forget that at the periphery, okay, around it, it will also be well endowed with perichondrum. So it is not only, yes, I want you to know that it is not only that of, in the case of the, hyaline cartilage, that will be having perichondrum, okay, but this one will also be having perichondrum, okay, surrounding this densely populated area of cells, larger cells, okay, and then having these elastic fibers in there. Now, you should be able to also tell us areas in the human body where we are going to find these elastic fibers. Okay, now whenever you think of this one, think about the ear apparatus, okay, the external ear by way of the pinna, okay, think about that one. Think about the external acoustic meatus, okay, or external auditory canal, think about that one. Think about, of course, the eustachian tube or the pharyngotympanic tube, okay, think about these ones. The ear apparatus, these things will be having a lot of these, elastic fibers. Don't forget about this kind of cartilage, which I failed to mention, as far as the laryngeal cartilages are concerned, the epiglottis, okay, will also be well endowed. And so we see the epiglottis, and we have to be seeing, okay, for it to be very firm, okay, we have to be seeing a core of this time around, not hyaline cartilage, not fibrocartilage, elastic cartilage. Okay, so please understand all these things I'm talking about over here. So there we are, as I was saying. Now, importantly, I want us to also go through some of these things. There is also another slide. Yes, you may be given a real-time session or whatever. But the point here is that this time, we are looking at the epiglottis. Yes, of course, we know that the epiglottis will be leaf-shaped, yes, so to speak. And so there's the guy I have over here. Remember, we are looking at the histological aspect, how we identify it. And so histologically, the epiglottis presents with two surfaces, yes, as you can see. So we have one surface over here, and then there's another surface over here, yes. Now this surface I am here, okay, this surface is what we call the anterior surface. Now, of course, microscopically, you can't tell that there's the anterior surface, okay? But the reason why I'm saying there's the anterior surface is that you can appreciate, okay, if you take a magnified section, you can see that the epithelial lining, okay, dips into the condensed lamina propria deep to it. And as I've said, whenever you see an epithelial lining showing epithelial pegs or epithelial ridges, then no doubt, you don't need to be confused at all. Regardless of how the section went, how the staining went, then you know that we are talking about stratified squamous epithelium, whether it is keratinized or non-keratinized. Yes, I made this clear to you last week about this one. And so what I see over here is that the epithelial lining, even in the magnified section over here, I can appreciate. So this is the epithelial pegs. So once I can appreciate epithelial pegs, I know that I'm looking at stratified squamous, non-keratinized. I don't see keratin over here, non-keratinized epithelium. Now the question is, why did I know that if this is the case, then it becomes the anterior surface? My friend, because that surface, whenever you are seeing that epithelial lining, it means it's in relation with the oral cavity. We know that oral cavity has to be robust, and whenever the epithelial lining don't be robust in a wet surface, then we know what the epithelial lining to be stratified squamous, non-keratinized. Okay, so this one becomes the oral part, and because it's the oral part, it faces that of the posterior aspect of the tongue, and that is why the anterior surface can also be called the lingual surface. So we have, that is actually the lingual surface of what we call the, of the epiglottis. Now, my friends, I won't end there, because my friend, the useful thing is that even the lingual surface goes all the way to even the apex and comes down even up to more than half of this other surface. And I want you to appreciate that this other surface, this time, it's not facing the tongue per se, it's not facing the oral cavity per se, but still, bad company corrupt good manners. And so there's no that kind of abrupt change. It goes all the way, it goes through that of the apex and even covers about one half of the opposite surface, which of course we call it the posterior surface. Don't forget about this. Whenever I talk about the posterior surface, is that portion which is in relation with, of course, the respiratory tract. precisely the larynx. And so this portion becomes the laryngeal component. Yes, the laryngeal component or the respiratory component of course, the epiglottis. Yes. And so it makes sense that you are supposed to have respiratory epithelium, which is pseudostratified, ciliated columnar epithelium with goblet cells. But is that what we see? No, we don't see that abrupt change occurring. So it can't so all the way even up to this point. Okay, so beyond this area, that's just an area that where we see the respiratory epithelium. So all this area is an oral epithelium. Okay, so please understand some of these things. But by and large, what do we see? We see two epithelial linings. Okay, stratified squamous, non-carcinized epithelium, and then what? Pseudostratified, ciliated columnar epithelium with goblet cells. Yes, but get to know that even the apex, okay, and I will say that the proximal half or more than half of it will still, okay, of the posterior surface will still be covered by what we call stratified squamous, non-keratinized epithelium. Now the point over here I want to highlight importantly is that sometimes, for instance, last week we talked about the tongue. That the tongue is an organ essential for gustation, for tasting. Then the point is it that it's only the tongue, okay, that will be well endowed with taste buds? My friends, that is no. And that is why I told you that, I mean, one important thing is that if you look at the posterior 1/3 portion of the tongue, yes, there will still be taste buds. Just that we don't see the primary lingual papillae. They are not located in the primary lingual papillae, but they are within the epithelium. And my friend, that's exactly the same thing we find over here, that although we don't see, okay, the papillae over here and then taste buds in there, even the anterior surface of the tongue will be having some isolated, taste buds over there. Okay, so as you can even appreciate over here, okay, even in the, that area, once we have stratified squamous non-keratinized, there could be that kind of isolated cases of taste buds in the epithelium. Yes, and I want you to appreciate that. So it will be relevant in gustation, in tasting. And it will also be relevant, okay, to be a protective mechanism that food is coming. So of course we know the role of the epiglottis, that it can quickly flap up to close the airway, okay, to sense that food is coming. Now please pay attention over here. What we see is that, especially if I look at the lamina propria, okay, if I look at the lamina propria, and of course even the submucosa over here. Now remember that lamina propria blends with the submucosa. That's the useful thing I want you to become aware of. Okay, so even over here at the lingual surface or the anterior surface, we don't see any gland in there. No, we don't see glands over there. But usually we tend to see the glands located in the respiratory surface. Yes, respiratory surface. Okay, as we move on, we'll be appreciating all those glands. Okay, so that it can help, moisten the air, humidifying the air and all that. Okay, now the glands over there usually are located in the submucosa, but simple, we still call them, mucosal glands. Still call them mucosal glands. The other point is that some of them may be in the lamina propria, but may go down into, of course, the submucosa over here. But my friends, importantly, and this is very useful that you have to comment on it. So forming a core to make it firm is this guy over here, and this time is something that we discussed already. This is the guy we just discussed. This time we are talking about elastic cartilage. Elastic cartilage forming a core over here. And as I told you, just like hyaline cartilage, elastic cartilage, around it, you will see this kind of dense irregular connective all around it. And my friend, that is something we call perichondrum. So you have to appreciate that we have hyaline cartilage, elastic cartilage over here, and there's also perichondrum. And that you can see the two surfaces, different epithelial linings. Okay, talking about where we find the glands in, of course, the, the laryngeal surface of the tongue. Great. Now, are we done with the larynx? No. The main wall of the larynx, this is what we see. This is how the larynx always look like. Okay, so now what am I talking about? We have the apical portion, which I said, that leaf-like guy, that's the epiglottis. Okay, some portion over here. of course, we are talking about the respiratory portion. And then from there, the majority of the wall of the larynx will be like this. Yes. And so what am I talking about? The apical portion will present with the fold, and that's the false vocal fold we're talking about. And that is also something we call vestibular fold. Vestibular fold. And then we have an indentation over here, so that we call it ventricle. And then from there we have what we call the true vocal fold. Not false, this time true vocal fold. And my friends, whenever you talk about the true vocal fold, okay, then that is the one you can also call the true vocal, course. Okay, so, and of course, this is the area where we'll be seeing a lot of the skeletal muscle. So now let's take our time and then of course go through this one for you. Now, first of all, if I look at this area, okay, which I have the vestibular fold, I'll be seeing some kind of glands. Some of them are deeply stained, so they are serous. Some of them are pale stained, they are mucous. Okay, will be all around over here in the lamina propria. Okay, in the lamina propria. Okay, but some may be invading, going into the submucosa also. Okay, so that's what we see. Of course, there are ducts may be present. Okay, I want you to appreciate that one. And then from there, now, so it goes all the way from at the lamina propria, that is deep, to of course this vestibular fold, and that of the ventricle. And then of course you will also be seeing these kind of isolated cases or the solitary lymphatic nodules. Now these solitary lymphatic nodules, because almost always we've inhaled some kind of air, then what is going to happen is that usually they will be having that kind of germinal center. So they will be secondary lymphatic nodules, or simply there will be lymphatic nodules over there. Okay, so that's what we'll be seeing. But usually they don't form clusters, and that's why it's interesting, it's important that you say that we have solitary lymphatic nodules. Okay, isolated cases of the solitary lymphatic nodules also in there. But you know something, once you inhale something from the external environment, normally these things will be present. Okay, lymphatic nodules will be present. Okay, we have the immune element, the lymphocytes. Okay, they are all in there. Okay, so that they can deal with all those antigens and all those foreign entities in there. Now, if you pay attention, you realize that over here, the lamina propria that we find, okay, and the region where we have the true vocal fold, that one we don't see. My friends, we don't see the serous and the mucous glands. Yes. Why? The reason is that this area is mainly for phonation. But we know that one other function of the larynx, okay, is for us to talk, okay, produce that kind of sound. And so this area, because a lot of vibrations over here, we are not really much interested in moistening whatever anymore. We are interested in some kind of protection. We need some kind of robustness. Okay, so we don't have these serous and mucous glands over here, overlying where we have the true vocal fold. And I want you to appreciate that one. Okay, now the useful thing rather that is over here is that we have thick, skeletal muscle fibers. This time around, I want you to appreciate that we have thick skeletal muscle fibers. So there's also another area where we'll be seeing skeletal muscle fibers. Okay, in the area of the true vocal fold. Okay, and so what are we seeing? This one, okay, we have skeletal muscle fibers, and because it's for phonation, then we are talking about vocalis muscle. Vocalis muscle, okay, over here. And my friends, one thing we know about vocalis muscle is that it's a medial modification of the thyroarytenoid muscle. Yes, a medial modification. And that is why if you come even downwards, you'll be seeing a lot of them. And this time around, it's not vocalis, but my friends, there are fibers, skeletal muscle fibers in transverse section. This time showing you that of what we call the thyroarytenoid muscle. Okay, so that is very useful that you appreciate it. Now, even beyond where we have the true vocal folds, these muscles, you may be having these isolated cases of these serous and mucous glands. But actually, in the fold, that area where we have the true vocal fold, okay, being very prominent over there, we don't see the mucous and serous, secretory acini. Okay, we don't see them over there. Of course, this is the area of the submucosa, but the submucosa is resting. Yes, I want you to appreciate it. It is resting on this guy over here. This time around, it is not the epiglottis, but this time around, we appreciate that, yes, although it will be having perichondrium, I can see perichondrium around it. It will be having perichondrium. It is not hyaline cartilage. Sorry, it's not elastic cartilage. This time around, it is hyaline cartilage. If you take a closer look, you'll be seeing that kind of cell nest, and you can also appreciate all these, elastic fibers. After all, yes, we didn't really use special stain to highlight these ones anyway. Then if I come down over here, I have that of the cricoid cartilage. Because this one mainly will be that of the, what you call the thyroid cartilage, and then of course the cricoid cartilage will be below it. Thyroid cartilage, then cricoid cartilage below it. Okay, so this is what we call the wall of what we call the larynx. You should be able to talk about all these features we're talking about. Now, quickly going on, the next guy I'm going to talk about is a trachea. Now, the trachea that the lay person calls the windpipe. Okay, that's where we are. Now, if you look at this, just a section shown to you, but it goes all around it, the trachea. The first thing that I want you to appreciate, that the trachea, first of all, you have to acknowledge that it will be having four tunics. Yes, well arranged. Now, the point is that always I take my time to talk about the trachea, because once you can appreciate the trachea, the remaining ones become so easy for you to identify. Now, how do I know? The first tunic is the mucosa. And whenever you talk about mucosa is made up of course, epithelial lining. And because this is related to the respiratory tract, what will be the epithelial lining? Yes, it will be what? Pseudostratified ciliated columnar epithelium with goblet cells. And that is something simply we call respiratory epithelium over there. Okay, so I'm not going into that detail because I've done these videos already. Go and get them and of course watch it, you have to. Then deep to it, we have lamina propria. Okay, so mucosa is made up of two things, an epithelial lining, which is respiratory epithelium, and of course the lamina propria. That's all. That's the first tunic. Now remember that the lamina propria is aglandular. It's important to appreciate that the lamina propria is aglandular. We don't have secretory acini, okay, in here, in the lamina propria. However, I go deeper to the lamina propria and I see an area where I see pale stained ones, which are the mucous acini, and of course the deeply stained ones, which are of course the serous acini. And so it means that we have glands over here in that connective tissue deep to of course the lamina propria. And my friend, that is the one we call submucosa. Now the question is there a thin line between the lamina propria of the mucosa and of course the submucosa? My friend, the answer is yes. Actually, the description of the lamina propria of what we call the trachea is that we say it is fibroelastic. So it tells me that there are a lot of elastic fibers. That is why it is recognized. Normally, we say it is fibrous connective tissue, then we talk about it. But this time we say it is fibroelastic. So you have some elastic fibers. But getting to that junction between the lamina propria and the submucosa over here, we see that it thickens up to become an elastic lamella or membrane. Yes. My friends, interestingly, and the routine hematoxylin eosin staining, yes, we won't see it. Unless if you want to highlight elastic fibers, I use for instance OC. So I won't see it. So that thin line, I'm not able to appreciate it under light microscope using the routine hematoxylin eosin stain. But one thing which tells me confidently that I've moved away from lamina propria to submucosa is the presence of these secretory acini. Yes. So I've seen two tunics, mucosa, and of course the submucosa too. Then what's the third tunic? My friend, this time around, the third tunic is this guy that I find over here, which I see a core, this time of hyaline cartilage. A core of hyaline cartilage. Now, whenever I talk about hyaline cartilage, the one thing that comes into mind is that I am supposed to see, of course, the perichondrium. And that is why I can see the perichondrium of dense irregular connective tissue all around over here at one side. Now, this hyaline cartilage, mainly which it is C-shaped, okay, continuous piece of hyaline cartilage. What I see is that it is in the, of course, the anterior aspect and of course the lateral aspect, but the most posterior aspect, it is not present. Okay, it's not present. Why? Because we don't need that cartilage, because behind this trachea we have the esophagus, which I say that is always collapsed. when no food is running through it. So immediately food begins to run through it and you have cartilage, then it may be causing that kind of dysphagia. Okay, you may even choke. And so God taught it wise, okay, to remove at the posteriormost aspects, okay, of what we call the wall of the trachea. We don't see this hyaline cartilage over there. And so there should be something which will bridge the ends of the hyaline cartilages. And my friend, that's why I can see some portion of it over here. That's that guy, which is a muscle, which because it's related to the wall of the trachea, we call it trachealis muscle. But my friends, importantly, I want you to acknowledge that it is made up of smooth muscle fibers. Yes, we said that in the case of the larynx, okay, where we had the vocal fold, true vocal fold, we saw skeletal muscle fibers, okay, in that transverse section. This time around, we are talking about what we call smooth muscle fibers, bridging the ends of what we call the C-shaped, okay, ring, continuous piece of, hyaline cartilage over there. That's useful thing I want you to appreciate. And then beyond that, yes, so beyond that we have something we call adventitia. So that's the fourth tunic, adventitia. And so what it means is that the third tunic, we don't only have cartilage, we also have smooth muscle. And that's why we call it, cartilago, or musculocartilaginous tunic. Usually I call it musculocartilaginous tunic over there. And then finally have your adventitia. Because this one is going to be fixed. Okay, I've explained this concept to you already. Okay, so we'll be having this adventitia, okay, gluing it to neighboring structures. Now, don't be surprised to see some of these, serous and mucous secretory sinai, even beyond the trachealis muscle. It's a bit weak, okay, unlike that of the hyaline cartilage. So some of them may go even in there, towards where we have the adventitia. But importantly, we want to see, okay, the serous and mucous glands confine themselves to, of course, the submucosa over here. Great. Now, once you appreciated that, then the next guy we want to talk about this time around is the bronchus. But my friends, it's not just any other bronchus, but this time around, it is an intrapulmonary bronchus. So it tells me that there will be another one, we call it extrapulmonary bronchus. And I'm going to explain by the end of this meeting. First of all, to tell you that it is intrapulmonary or extrapulmonary, it is based on the presence or absence of the lung parenchyma, the lung tissue. Okay, the spongy-like appearance, okay, of the lung tissue over here. If it is present, if you can appreciate it, then it means it's an intrapulmonary, it's within the lung. But if you cannot appreciate it, then it becomes extrapulmonary. Yes. Now, first of all, whether it is intrapulmonary or extrapulmonary, generally we're talking about 5 tunics. Trachea, I'm talking about 4 tunics. This time I'm talking about 5 tunics. Okay, I'm going to explain. So it means that first we'll be having mucosa, okay, respiratory mucosa, and for this reason the epithelial lining will be respiratory epithelium, which we said is going to be pseudo-stratified ciliated columnar epithelium with goblet cells, and then also we'll be having lamina propria, okay, lamina propria over there, forming the mucosa. So number 1. Number 2. Now, in the case of what we call the trachea, once I moved from the mucosa, I went to where the glands were, which was the submucosa. And I said that something was separating the lamina propria, okay, from, of course, the submucosa, which was, of course, the elastic membrane, which I said that you couldn't highlight it using the routine H&E. This time around, in the case of the bronchus, it's a different story altogether. We don't see elastic membrane separating the lamina propria from, of course, the submucosa, no. This time around, we see smooth muscle fibers. Okay, so I can see smooth muscle fibers. And that's why initially I told you about the smooth muscle fibers over here. So in the wall, it's not only in the trachealis muscle that we find smooth muscle fibers. In the bronchus, we'll be having smooth muscle fibers. This time around, separating the lamina propria from the submucosa. But the useful point I want you to appreciate over here is that this smooth muscle is not that thick. Because my friends, the thickness of the smooth muscle will even help us know that is it that we are talking about the bronchiole or whichever. Because my friends, if I look at the bronchiole, whether it's the pre-terminal bronchiole or the terminal bronchiole, I'll be seeing thick, smooth muscle fibers. So this time around, it's not that thick. That's the first of all, the first thing I want you to know. But still, we are considering it to be a tunic. So far I've seen 2 tunics. Mucosa, number 1, and of course, this muscularis that I have over here, smooth muscle over it. So that's number 2. Now the third one will of course be my submucosa, because that's the one where you separated the lamina propria from the submucosa. Okay, so this one. And my friend, just like we saw in the case of the trachea, this time around too, you'll be seeing serous and mucous acini, which tells me that the lamina propria is aglandular, but the submucosa is well endowed with glands. Yes. So already I've seen 3 tunics. Now what's the 4th one? The 4th one, just like we saw that we had a cartilage, you'll be seeing cartilages all over here. The same way we are talking about hyaline cartilage, and therefore they will be surrounded by dense regular connective tissue perichondrium, okay, around it. Yes, that's what we see. But this time around, the useful thing is that it is not a continuous piece of hyaline cartilage. It's broken up. There's that kind of discontinuous disposition of the hyaline cartilages, okay, in the wall that we find over here. So okay, I have one over here, I have one over, so it goes around it in that manner. Discontinuous hyaline cartilage. Then what's the next one? I'll be having the connective tissue adventitia to glue it, okay, to neighboring structures. Okay, so that is what I'll be seeing over here. And as I said, the distinction that you know that there's an intrapulmonary is the presence of the lung tissue that we find over here. Okay, so that is the useful thing. Now the next guy, which I want to rapidly go through it, is this time around something we call the terminal bronchiole. Terminal bronchiole. But before I go to terminal bronchiole, the point is that the definition of a bronchiole is that its luminal diameter should be less than 1 millimeter. Yes. Okay, so that becomes a bronchiole. Now, if it is less than 1 millimeter but greater than 0.5 millimeter, it becomes a pre-terminal bronchiole. Okay, or something I call the initial bronchiole. Okay, that is the first, or something you may also call the primary bronchiole. Now, what do we see? Whether it is the pre-terminal bronchiole or the primary bronchiole, normally you'll be seeing certain features in common. But the first thing I want you to appreciate that in the case of the pre-terminal bronchiole, you may be seeing some isolated cases of goblet cells. The epithelial lining will also be higher or be taller, so it will be, of course, simple columnar epithelium, okay, with cilia. In the case of the pre-terminal bronchiole, yes, and you may be seeing isolated cases of goblet cells in there. But my friends, in the case of the terminal bronchiole, you'll be seeing, that is in the situation when the lunar diameter gets below 0.5 millimeter, you'll be seeing this time around clamped cells. Instead of goblets, there will not be any goblet cells, and the epithelial line will be shorter. Okay, so I'm talking about low columnar epithelium in the case of what we call the terminal bronchiole. Okay, and importantly, whether it is pre-terminal or terminal bronchiole, I'll be seeing something. I'll be seeing 3 tunics. 3 tunics. And what are these 3 tunics? The mucosa, which is made up of the epithelium, which I've described, and of course the lamina propria. The second tunic, this time, as I told you, in the case of the bronchi, or whichever bronchus I'm talking about, okay, we said that the smooth muscle was thin, but this one is very prominent in the case of the terminal or pre-terminal bronchiole. Very thick, consistent, smooth muscle fibers. And that is why, importantly, because of the contraction of these smooth muscle fibers, you'll be seeing that the lumen, so the luminal margin, okay, will be thrown into this tailor-shaped manner. You'll be seeing all those folds, and then you'll be seeing the tailor-shaped luminal margin over here. Yes, that is what we'll be seeing. And then from there, you'll be talking about the adventitia. And then still, this one is within the lung, and that's why we'll be seeing the lung, you know, parenchyma over there, the blood vessels and all that, they will be there. Okay, so I want you to really understand this concept. Now, the other thing which I'm ending with, okay, which I've seen a lot of the lung parenchyma around, they are still within the lung, and this time around, the respiratory bronchiole. Okay, so you can call the pre-terminal bronchiole, of course, the primary bronchiole, can tell the terminal bronchiole, the secondary bronchiole, and then the tertiary is the respiratory bronchiole, where of course that kind of exchange also takes place over there, exchange of gases. This time around, we don't have smooth muscle going all around it. Okay, so there are patches of smooth muscles around. Why? The reason is that there will be some areas, okay, some space over there where the smooth muscle will not go around. And so we won't see the lumen showing that stellate shaped luminal margin. And we'll be seeing all these discontinuities. Something we call them alveolar output curtains. Alveolar output curtains. So of course the air can easily escape, go into alveolar duct, and eventually into alveolar sacs, and of course the alveoli. Okay, so I want you to appreciate this time around. In the case of respiratory, bronchiole, the epithelial lining is simple cuboidal epithelium. Okay, usually you don't want to see, cilia, but you may be seeing some piles of cilia also around. Okay, so I want you to understand this. Okay, and then the smooth muscle will not be that consistent, and I want you to appreciate that. So for instance, if I'm talking about the bronchiole, whichever bronchiole I'm talking about, you have to acknowledge that there will not be any serous and mucous acini or mucous glands. There will also not be any cartilage, but this time around, the smooth muscles, okay, will be present. Okay, talking about in the case of respiratory, bronchiole, talking about the alveolar output curtains leading into alveolar ducts, okay, and then alveolar sacs and all that. Okay, so my friends, this is where I bring the second part of this, identification of histological identification of organs, okay, with you. Intermittently, I'll be bringing in, chipping in some of these things, okay, but for now, I may focus on something else, okay, as far as the developmental anatomy is concerned, and then we see the way forward. I'm very grateful for your time this evening. Have a good night, all of you, and may the good Lord richly bless you. Amen.